welcome to this Immune-Mediated Inflammatory Disease Forum entitled IL-17 Inhibition, Controlling Inflammation and Disease Progression in SpA. My name is Sofia Ramiro. I'm a rheumatologist from the Netherlands, and it is my pleasure to chair this webinar here today and to be accompanied by my esteemed colleagues and faculty who will make this webinar here today with us. So we are accompanied by Professor Iain McInnes, well known to everyone from Glasgow, Professor Atul Deodhar, also expert in actual SpA from the US, and Professor Laura Coates, expert in PSA from Oxford. And together we will be the faculty for this webinar. I would like to first show my disclosures and continue now with some housekeeping. Actually, first I would like to mention that this is a webinar that is possible thanks to UCB, who supported this activity through an independent educational grant. And now we would like to get started with some technical aspects. Well, you will all be muted during the meeting, but we really encourage your participation. We would like to have an interactive webinar and not only us producing, sending content to you. So please put your questions in the chat. I will be monitoring them and I will ensure you that they will be asked to the speakers at the end. But throughout the webinar, please don't be shy and ask all your questions. That's why we're here for, to make it more interactive. So we will have program, and yes, here's the agenda of our webinar. So we will start with the pathophysiology of SpA and the role of IL-17A and IL-17F by Professor Iain McInnes, continuing on the role of IL-17A and AF dual inhibitors in the management of actual SpA by Professor Atul Deodhar, and then the role of IL-17A and IL-17A and F dual inhibitors in the management of PSA by Professor Laura Coates. And in the end, we have time dedicated to a Q&A, so please send your questions during the webinar. We will be making sure that they will be asked to the speakers and will be covered during the webinar. And without further delay, I would now like to introduce our first speaker, very well known to all of us. Unfortunately, he could not make it to be with us at this precise moment, but he did not want to miss this webinar, so he made sure that his presentation was recorded. So we will now have the presentation from Professor Iain McInnes on the pathophysiology of SpA and the role of IL-17A and IL-17F. So let's listen to the presentation from Professor Iain McInnes.
Well, Sophia, thank you ever so much for that very kind introduction. And what a joy it is to talk to you all about one of my favourite subjects, the pathophysiology of spondyloarthritis. And today I'm going to talk a little bit about that in generality, but I'm also going to focus down particularly in the roles of the IL-17 superfamily of cytokines, which are utterly fascinating. Now, these are my relevant disclosures, which you can see in front of you, and concern a whole number of companies who have been involved in the development of medicines that are currently used or may in future be used for the treatment of people with the SpA syndrome. These are my learning objectives. Well, I want to talk a little bit about the general factors, particularly focusing on those immunologic factors that contribute to the pathophysiology of spondyloarthritis. And then I'm going to drill down a little further and explore the particularly fascinating roles played by members of the IL-17 superfamily, and I'll introduce that to you momentarily. And of course, all of this is focused around trying to understand the pathogenesis, the inflammatory mechanisms that underpin a disease which exhibits huge clinical heterogeneity. And I think we're just beginning, we're on the cusp of understanding why that clinical heterogeneity occurs. Well, it's been quite the time to be working in the SpA field over the last 10, 20 years or so. It's not so long ago when we had pretty much no approved medicines with a primary focus on the pathogenesis of SpA. We tended to borrow medicines from other areas, think methotrexate, and then of course the TNF inhibitors, of course, approved for the use in psoriatic arthritis and in then ankylosing spondylitis, and more recently non-radiographic axSpA and SpA itself. But those were indications that came after the original discovery of the role of TNF blockade in rheumatoid arthritis. What we've seen gradually over the last 2 decades is a shift from medicines borrowed to medicines innovated primarily on an understanding of the pathogenesis in SpA. And that's certainly the case when we start to think about the IL-17A, IL-17F, and IL-23 inhibitors. So this timeline is simply a depiction of the new medicines that have come on board and the increasingly exciting role that pathogenesis understanding has in allowing us to develop new and potentially effective medicines. So let's start with the rather obvious conundrum that this disease spectrum poses to us. There are many different tissues that are involved. Skeleton, axial skeleton, peripheral skeleton, the inflamed synovium, the enthesis, potentially the eye, potentially the gut, and very frequently the skin. At a clinical level, there are some very well established upstream describers. So first of all, there is a genetic predisposition. I'll deal with that momentarily in a little more detail. Smoking, particular interest at the moment in obesity, causal relationship between obesity and the likelihood of developing psoriasis. So no longer can we think of metabolic syndrome, cardiometabolic syndrome, obesity as it's a consequence or it's a comorbidity. It's actually part of the fundamental pathogenesis of disease. And we're not really at a stage of understanding quite how that works at the molecular level. But as we understand that, so too new innovations will occur, particularly in these days of GLP-1 agonism and other new evolving therapeutics. But also there's interest in infection, primarily infection, the classic infection-related activation of psoriasis, skin disease, but the much subtler impact, for example, that might exist in, for example, the microbiome. And of course, an underlying role potentially for biomechanical trauma, particularly thinking about the enthesis, and for alterations in the cutaneous microbiome, the so-called dysbiosis. All of that in turn leads to recognizably and reproducibly present comorbidities. And I've depicted them in this slide for you. You know what they are. They're present in so many of your clinics. And the comorbidities of metabolic syndrome, which, as I've indicated already, may well be causally related, but also issues such as atherosclerosis, accelerated cardiovascular risk, depression, and others. So this is a really complex, clinically heterogeneous tissue sets that we have to explain somehow. And I want to just put in your mind the thought that not all tissues will behave in an immunologically identical manner. And that therefore means that not all immune pathways will have equivalent levels of dominance in the immune responses that take place in different tissues. And as a very simple example, think about the difference between the skin and the eye. The skin can actually tolerate quite large volumes, surface area, if you like, of inflammatory lesion. And there's no great evolutionary imperative there. The skin will be inflamed. It will presumably, unless you reach an erythrodermic state, it's not going to be life-threatening. But even a relatively small amount of inflammation, surface area-wise, in the eye will render a person blind. And that has huge implications for their future well-being, their ability to contribute to society, but also, if you think about it, their ability to contribute to the gene pool. And so there have been quite strong genetic influences on the way in which different tissues have evolved their immune defense. And it should be no surprise, therefore, that a single intervention may manifest quite different outcomes when we intervene in a cutaneous response, a GI bowel response, an eye response, or a joint response. And that's why, in fact, individual biologic drugs sometimes elicit so-called idiosyncratic, but in my view, evolutionary, quite easy to explain responses in a given tissue. So quite the challenge we've set ourselves. Let's take a few lessons. Well, first of all, let's start with genetics. And this, if you're interested, is quite an accessible review that was published just 2-3 years ago, depicting a whole range of genes that are associated either with the likelihood of occurrence of the SpA spectrum or the severity of SpA spectrum. And for added measure in here, we've thrown 1 or 2 other immune diseases, rheumatoid, type 1 diabetes, and inflammatory bowel disease, lupus. And what you see is that there are pathways that are commonly involved across a range of immune disorders, but also pathways that depict the likelihood of developing or severity of progressing cutaneous disease or PSA. And even within PSA, there are genetic antecedents that code for skin disease but not joint, joint disease but not skin, and then a larger majority of genes that depict risk in both tissue domains. So the genetics, when we unpick them, are really quite subtle. But notice, for example, genetic risk for IL-17A, for IL-23 receptor and IL-12B receptor. In other words, IL-17F. In other words, right from the outset, we see genetic risk that points to potentially important pathogenetic factors. Now let's start to integrate all of that into a model of pathogenesis. I've already run through the clinical things we know important: mechano inflammation, metabolism, obesity, and the presence of skin inflammation per se, altered permeability perhaps, and the idea of gut or cutaneous barrier dysbiosis. Now, this is actually rather a complex slide, but if you read from outside to the center, what you see are potential inducers, immunological inducers. And as you just cast your eye, the detail doesn't matter for purposes of this short lecture, but as you cast your eye around, there are a whole range of immune factors, different cell types, dendritic cells, keratinocytes, adipocytes potentially, in the gut intestinal epithelium, that will be part of the response in the enthesis, the tenocyte. And those stromal cells that sense pressure, that sense mechano-inflammatory challenge. That in turn leads to enhancers, and this is where we meet the IL-17 family for the first time, the IL-17A, 17F, acting as amplificatory factors that will work. One of the things the IL-17 family do is they act as synergens. They work with other inflammatory molecules to amplify and accelerate disease. And then we have effectors, molecules driven, for example, activating macrophages, activating neutrophils, activating pain sensors, activating in turn keratinocytes, enterocytes, synovial fibroblasts. So let's think a little bit more about the potential contribution that the IL-17 family have. Now, IL-17 used to be called a single cytokine. It's now known by to have many different family members. And I want to focus today on IL-17A and IL-17F, which share genetic risk in PSA and axSpA, as I've already mentioned. The IL-17 family is clearly, first and foremost, it has evolved for host defense. And in health, the IL-17 superfamily have really important roles in wound healing and in barrier function, which is why inhibiting it might not be the greatest idea in inflammatory bowel disease. In metabolism, in thermogenesis, but also in the infectious response, particularly corresponding to fungal defense. But then it's also a family that have been implicated in disease states, and you can read them for yourself on this slide. And this is derived from genetic risk, from the presence of IL-17 superfamily members in investigated tissues, and also most recently from the benefits accrued on immune-specific targeting using primarily biologic agents that exquisitely selectively take out IL-17A and more recently IL-17A and IL-17F. So here is, if you like, a summary of what I'm going to tell you in the next 10 minutes. So if you need to sleep, then now would be a good time. You've accrued all the information you need. So we've got this environmental genetic background that I've mentioned. It activates the immunologic compartment, depicted here as mainly lymphocytes, that in turn release IL-17A, which is a homodimer, IL-17F, also a homodimer, but also a so-called heterodimer where one A molecule binds with one F molecule to create IL-17AF. Intrinsically logical, I hope you'll agree. That in turn has the effect of activation of keratinocytes, fibroblasts, synoviocytes, enthesial cells, and others. That in turn leads, at least hypothetically, to the inflammatory sites that we see that are utterly characteristic of the axSpA spectrum. And so we've depicted here a direct effector link through the activation of these stromal, tissue-specific selective cell lineages, and by their activation, the manifestation of disease. Now, This is, again, quite an accessible review that Orly Nam put together with a small group of us in Glasgow just a couple of years ago. And if you're interested, have a look. It's a detailed appraisal of just how we get from inflamed skin, inflamed synovium, inflamed enthesis, through mainly the IL-23 family upstream, driving the downstream release of IL-17 family members. And at this point, we depicted only the IL-17 family in this figure. And you can see a role for IL-17 as a direct effector in at least these three clinical manifestations of disease, at least. So let's just explore a little bit more the introduction I've given to the family, the homoheterodimer family. So I've told you already, we have 17AA, 17FF, and 17AF. Now, they all bind to the same receptor complex. And you can deduce from that that the effects that these three different cytokines will have will be pretty similar because they bind the same receptor. And so they bind to a heterodimeric receptor, IL-17RA, IL-17RC, and that receptor then drives the changes in gene expression in the cells that I've now depicted for you: keratinocytes, fibroblasts, enterocytes, synoviocytes, etc. So have that in mind when we think about what inhibitors might do, and you'll hear about that later on in this symposium. There are, broadly speaking, two different classes of lymphocyte that produce the IL-17 family members of interest. Innate-like lymphocytes. Now, some of you, when you were at medical school or university, will be told there were lymphocytes. Well, of course, lymphocytes now exist in numerous subsets. And the IL-17 producing lymphocytes are innate-like gamma delta T cells, ILC3s. They are driven by IL-12 and IL-18 mainly. Whereas the adaptive lymphocytes, that's the Th17 cells that you've been taught about, are driven mainly by IL-23. Now, notice something really important. There are sources of IL-17 in inflamed tissues that are independent of interleukin-23, and in theory, therefore, could be bypassed if we only give an IL-23 inhibitor. That's quite an important factoid to hold on to for later. So now what I want to do is just in a short number of minutes share with you some examples of the immunology that underpins this. And as I say, please don't dwell on the detail, think more about the principles. So we can create in vitro models. I think that's maybe overstating it, but we can create in vitro representations of what we think IL-17A and IL-17F might do. And what you're seeing in this slide is fibroblasts and synoviocytes and perienthesial bone and enthesial soft tissue stromal cells. And what we're looking at here is the effect on activation of those cells measured in the top panels by the release of a chemokine, IL-8, and in the bottom panels by the release of a different chemokine, CCL20. So these are simply measures of cellular activation. It's less to do with IL-8 now, CCL20, and more to do with are the cells activated or not. Now, what you'll see is that the control cells are not releasing. If you look at all four panels, it's the same message. Control cells release very little. Addition of TNF in its own. Now, you were taught that TNF was very inflammatory, but look, TNF its own it induces release of chemokine, but not so much. But look at what happens when you add IL-17A or IL-17F. That's the synergistic enhancement effect that I mentioned. And in all four cell systems, 17A and 17F synergize with TNF. I could have shown you a very similar picture had I had IL-1 in the system. So it's an amplificatory factors. So now you're saying, well, why have we got A and F? Well, it turns out that they've been evolutionarily conserved, and they are different. They are they show discrete regulation. So, for example, STAT3, which is a signal processing molecule downstream of the JAK signal complex that you know a whole lot about through the JAK inhibitor story. STAT3 enhances expression of 17A. STAT5 enhances expression of 17F. In other words, we can quite comfortably differentially regulate A and F in tissues. So we shouldn't make the assumption that they're completely synonymous one with the other. The immune system will call on one or the other at different times. And time is of the essence. So this is a very elegant experiment in which cells taken from human peripheral blood have been cultivated in the presence of an activator, anti-CD3, anti-CD28, and a little bit of PMA-ionomycin. So this is a kind of polyactivator. And if we polyactivate peripheral blood cells, that are CD4 T cells, you will see initially high levels at 6 hours of IL-17A. It's a FACS plot. The dots in the top left-hand bar depict 17A expression. But look at what happens over the next 2 or 3 days. By 72 hours, the predominant cellular expression is no longer of IL-17A, but it's the bottom right-hand panel, IL-17F. In other words, over time, when cells are under stimulus, analogous to their position in tissue, they become 17F dominant. So what that tells us is that over time, 17F becomes the default pathway. Now, the next part of the discussion is whether these cytokines are actually present, and the answer is yes, they are. So you're looking at non-lesional skin, at lesional skin on the top left, at psoriatic skin, top right, where you're starting to look at non-lesional, lesional, but on the left-hand side, you're looking at the number of cells expressing IL-17 types. On the right-hand side, the actual amount of IL-17A or F. And what you see is interesting. There are more cells expressing 17F than A, and the absolute amount of 17F is greater than 17A. So although 17A is a bit more potent, there is more 17F around. So the two actually counterbalance each other. And the prediction of that, you see something similar in the bottom when you look at 17F expression in parenthesial bone. And again, in the bottom right-hand panel, you see, again, consistent with what I show you, particularly for gamma delta T in MALT cells, that 17F only expression is the majority appearance. In other words, there is 17A and F expression, and that dual expression is more likely to favor 17F. This is also true when we look in a clinical study. This is a biopsy study in which patients were biopsied, their skin biopsy, in non-lesional skin, lesional skin, and then lesional skin 8 weeks after dual 17A/F inhibition, achieved again using bimekizumab. And what you see here are gene signatures in the top, inflammatory cytokines, 23, 17A, 17F. In the center panel, chemokines. In the bottom panel, more amplificatory cytokines, 17C, IL-36, a member of the IL-1 superfamily. And what should catch your eye here is that after treatment with the dual 17A/F inhibitor, which we would now argue is the optimal pan inhibitor of the 17 family over and above mono 17A inhibition, you see that there is a high level of normalization of inflammatory cytokine, chemokine, and amplificatory factor when you compare post-therapeutic lesional skin with non-lesional skin at baseline, quite similar and very different from the blue lesional skin profile pre-therapy. So let me summarize, ladies and gentlemen, what I've told you today. It's a very clinically heterogeneous disease that calls upon clinically heterogeneous resolution of the immunological pathways. And we're doing that with the new molecular therapeutics that we're using. We're starting to dissect out the impact of different biologics in different tissues across the SpA spectrum. There is a huge range of genetic, immune, environmental factors at work, and we're still, I think, at a relatively early stage of understanding how these different factors work across different tissues. Certainly, there are numerous cytokines present, and we know therapeutically that TNF inhibition, 23 inhibition, 17A, and now dual AF inhibition are all biologically effective in our patients. So all are clearly functionally prominent. But I think the immunology, and I suspect in due course the clinical trialing, we'll hear a bit more about that in this webinar, point to the value of dual inhibition, 17A and F, when we target that cytokine family over monotherapeutic inhibition. Certainly that's the direction that the immunology is taking us. And with that, Sofia, I'm going to hand back to you, looking forward to hearing what my very learned colleagues will tell us about the clinical consequences of this immune biology. And although I'm not going to be with you in presence, I'm going to be with you in spirit, and I'll be learning as I look at this in reflection at a later time. Thanks ever so much for your attention. I'm looking forward to hearing how the rest of the webinar goes.
Well, thank you very much, Iain. It was, as usual, a very insightful presentation, and now setting the role of IL-17 inhibition, and particularly IL-17A and also IL-17F. And now we will turn our eyes to the application in clinical practice and trial programs, as Iain has already mentioned. So without further delay, I would like to introduce again Professor Atul Deodhar, who is a professor of medicine from Oregon Health and Science University, Portland, from the US, and who will now tell us about the role of IL-17A and IL-17AF dual inhibitors in the management of SpA. Atul, please, the floor is yours.
Thank you. Thank you so much, Sofia. These are my disclosures. And the learning objectives of my talk are to review the clinical data on the efficacy and safety of IL-17A single inhibitors as well as IL-17A and F dual inhibitors. And the way I'm going to do this is by showing you data from the clinical trials. I'm going to also talk about the integration at the end. Where exactly are we going to use the IL-17A and F, the new drug on the market is bimekizumab, in the current treatment paradigm that we have in our practice. So this slide shows the current FDA-approved treatment options for axial spondyloarthritis. And what you see on the top is the radiographic axial spondyloarthritis, the top row. And at the bottom is the non-radiographic axial SpA. As you know, depending upon the sacroiliac joint X-rays, if there is definitive changes, we call it radiographic. And if it is not definitive changes, we call it non-radiographic. And there are three sets of drugs: TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. The ankylosing spondylitis or radiographic axial SpA has got multiple drugs available to treat. And at least in the US, the FDA-approved drugs for the treatment of non-radiographic axial SpA are limited. Only there is certolizumab pegol in the TNF inhibitors section. The IL-17 inhibitors shown here in the middle, two of them, secukinumab and ixekizumab, are IL-17A inhibitors, and bimekizumab is both IL-17A and F inhibitor. These three drugs are available, FDA approved, to treat both radiographic as well as non-radiographic. On the JAK inhibitors side, upadacitinib is the drug that is approved for treating both types of axial SpA. Tofacitinib has only done clinical trials in radiographic axial spondyloarthritis. So let's talk about secukinumab and ixekizumab, secukinumab being the fully human monoclonal antibody, and ixekizumab is a humanized monoclonal antibody. Secukinumab, this is now 10 years ago, this trial was published in New England Journal of Medicine. This is, they actually did measure 1, measure 2, measure 3, measure 4, and measure 5, 5 phase 3 studies. Here we are only looking at measure 1 and measure 2 studies. These are phase 3 studies, double-blind randomized placebo-controlled study. At that time, we used 75 milligram and 150 milligram dosages of secukinumab. And the only difference between measure 1 and measure 2 is that in measure 1, the loading doses were IV secukinumab, 10 milligram per kilogram. Remember that number because later on I'm going to talk about IV secukinumab, which is now available in the US in a very different dose. But in measure 1, the loading dose was 10 milligram per kilogram at baseline, week 2 and week 4. And after that, it was subcutaneous secukinumab, whereas in measure 2, it was all subcutaneous secukinumab. It was loading dose was also subcutaneous secukinumab at baseline, week 1, week 2, week 3, week 4. And that's the dose that has been finally approved, the 150 milligram subcutaneous. So the graphs that you are seeing here are both from measure 2 study. And on the left-hand side, you see the ASAS40 response, ASAS40 response, and on the right-hand side, the ASAS20 response. So at 16 weeks, the primary endpoint, which happened to be ASAS20 response, was met by 61 compared to 29% in placebo of patients. This was in the measure 1. And in measure 2, similar numbers. So this was a successful, both studies were successful based on which FDA approved this drug. Candida infection is the one that is the adverse effect of interest, because IL-17 is useful for us in daily life to prevent Candida infection on surfaces. So on the skin, on the mucosal membranes, etc. And in inflammatory bowel disease, it was 0.9 and 0.7 in these two trials. This, interestingly, has remained remarkably stable in all the studies. What you're seeing here is the PREVENT study. This is secukinumab in non-radiographic axial spondyloarthritis. FDA has suggested that we should do a placebo-controlled study all the way up to 52 weeks. However, EMA had suggested that 16 weeks is enough. So this particular study had two different kind of endpoints, and you're looking at 16 weeks as well as 52 weeks. This is now 150 milligram of secukinumab subcutaneous used. However, there was load and no load. So load is, of course, secukinumab used the way we use it currently, which is baseline week 1, 2, 3, and 4. No load is secukinumab 150 milligram at baseline and then every 4 weeks. In both load and no load, the drug was shown to be effective, statistically significantly different than placebo at week 16 and at week 52 as well. Here is the IV secukinumab study that was recently published. Here, the dose of IV secukinumab was 6 milligram per kilogram at baseline, and then 3 milligram per kilogram after that, up to week 52. And despite all these different dosages, the final dose that was approved by the FDA is 1.75 milligram per kilogram. So we have come all the way from 10 milligram per kilogram used in the first study that was done, which I showed you, published in New England Journal of Medicine. This IV secukinumab study had used 6 milligram and then 3 milligram. And finally, the dose that we have is 1.75 milligram. Be as it may, in this particular study, ASAS-40 responses were statistically significantly different and significant for IV secukinumab compared to placebo. This is looking at the 5-year integrated pooled clinical trial safety of secukinumab in axial spondyloarthritis. And I want to draw your attention to the candida infections on the right-hand side top. Generally, our experience is that the candida infections occurring in patients on IL-17 inhibitors, and this is also true for ixekizumab and bimekizumab, happen generally in the first year. After that, these candida infections go down. Inflammatory bowel disease, shown here as Crohn's and ulcerative colitis and IBD on the left. Overall, the number is 0.8 per 100 patient years. And this is, I actually use this number to counsel my patients in clinical trials as well. That brings us to ixekizumab, the second IL-17A inhibitor. There were two trials. COAST-V was the trial which was on TNF inhibitor naive axial spondyloarthritis patient. COAST-W, these were radiographic axSpA, and COAST-W was those who had at least one TNF inhibitor inadequate responder. The graphs that you're seeing here are in the COAST-W study, which is the TNF inhibitor inadequate responder patient. Patients were randomized. Now here, the randomization is between placebo and two different dosages of ixekizumab, 80 milligram every 2 weeks and 80 milligram every 4 weeks. The dose that is approved, as you know, is ixekizumab 80 milligram every 4 weeks, subcutaneous. And as you see here, the orange line is this ixekizumab every 4 weeks. The ASAS-40 response was achieved by about 31% of patients on every 2 weeks, whereas nearly 25% of patients on ixekizumab every 4 weeks versus 12.5% patients on placebo. Remember, these are resistant patients in a way because they have already tried and failed one TNF inhibitor. The side effect profile was very similar in this study as well as in the COAST-V study. An interesting question is always raised is that can we treat patients with radiographic axSpA without objective signs of inflammation? And we specifically looked at in the combined database of COAST-V plus COAST-W. And what is shown on the left-hand side is patients who had low CRP, less than 5 milligram per liter, and did not have inflammation on the spine, the spark inflammation score less than 2. And it's still, ixekizumab was effective when compared to placebo. So the reluctance that some people have about using these agents in radiographic axSpA. In non-radiographic axSpA, we generally do not use biologics if they have got completely normal or there is absence of inflammation. But in radiographic axSpA, the story is different. Here is ixekizumab COAST-X study. This is non-radiographic axial spondyloarthritis. Again, there are two endpoints here at week 16 and week 52. And ixekizumab every 4 weeks, 80 milligram, is statistically and clinically, of course, significantly different and efficacious compared to placebo. COAST-Y, this is a pretty complicated study, and don't worry about this complex study diagram here. But the question this study was trying to answer is, can we taper the dose or can we stop ixekizumab after patients have been into an inactive disease state, which is ASDAS of less than 1.3. So patients who participated in COAST-V, which was TNF inhibitor naive population of radiographic axSpA, COAST-W, which were TNF inhibitor inadequate responder radiographic, and COAST-X, which is non-radiographic. All those patients, if they were in inactive disease, then they were entered into the study. And a part of those, some of the groups of the patient, they actually stopped, they withdrew the treatment and they were given placebo in a blinded fashion. And the interesting part is on the next slide, which shows, which shows that flare-free responses. And of course, those who continued ixekizumab without stopping it, they had better outcomes compared to the patients who were blinded in a blinded fashion who stopped the drug. What is exciting to me is if you look at this gray line at the bottom here, that shows that nearly 55% of the patients at the end of 40 weeks, after they were withdrawn, 40 weeks later, they were still in inadequate, inactive disease, ASDAS of less than 1.3. So you can look at it as glass half full or glass half empty. But interestingly, this one shows that patients can still be in inactive stage. This is long-term safety of ixekizumab. This is pooled analysis of psoriasis, psoriatic arthritis, and axial spondyloarthritis. I want to draw your attention to these light green bars. These are axial spondyloarthritis, and the numbers are quite similar. The inflammatory bowel disease is this 0.8 per 100 patient years. Candida infection is about 1.2 per 100 patient years, etc. Overall, it is very similar and constant amongst different drugs. Bimekizumab is the only drug which now blocks IL-17A plus IL-17F, and two studies were done, B-Mobile 1 study in non-radiographic axSpA and B-Mobile 2 study in radiographic axSpA. Both of them had ASAS-40 response at week 16 as the primary endpoint. Studies were continued till week 52. And this very colorful diagram shows how patients went from this very inflamed disease. Bright red or dark red is very high disease activity. Orange is high disease activity. And if you go from left to right, and the left-hand side bar graphs are for non-radiographic, the right-hand side bar graphs are for radiographic. But just visualizing it, you can see that patients are going from bright red to green, indicating that patients getting into inactive disease even at week 24. More than 50% of patients have gone from high disease and very high disease activity to low disease activity or inactive disease. One interesting feature of this combination therapy of IL-17A plus F is that uveitis seems to be controlled on this particular drug. And what it shows is that patients who were, all patients versus those who had history of uveitis, when given bimekizumab, it appeared to be that the rate of the new incidence of uveitis has gone down. So the question is whether IL-17A plus F might actually inhibit new onset or new uveitis rates. This is looking at 5-year results from the B-Agile, which was the phase 2 study on bimekizumab. And this shows again very consistently that The fungal infections shown here at the bottom right, this is again mostly Candida, occurs mostly in the first year, and later on it kind of goes down. Inflammatory bowel disease is again very low at 0.8. How does bimekizumab compare to other biologic DMARDs and as well as, of course, IL-17A inhibitors? This is the question. There are no head-to-head studies. So this is a network meta-analysis, and I want to draw your attention to the right-hand side where those red circles are. And what it showed was the bimekizumab efficacy overall was similar to all the drugs that we have in our armamentarium. However, on a very small a very small subset of patients who received secukinumab, and these were patients who were biologic naive patients on secukinumab. In this network meta-analysis, this is not head-to-head study. Bimekizumab was superior compared to secukinumab for ASAS-40 response and ASAS partial remissions response. Question is, are they disease modifying? And here is a head-to-head study of secukinumab versus adalimumab biosimilar SURPASS study, phase 3B study. And what is shown here is the cumulative percentage plot on the top right here. And there is no difference. And this is comparison of secukinumab versus adalimumab biosimilar head-to-head randomized controlled study. And interestingly, what you see is that there was no difference. And if you look here on the left-hand side at the bottom, the progression as measured by the modified Stoke ankylosing spondylitis spine score, MSAS, it is very minimal, 0.54 for secukinumab versus 0.72 for adalimumab. In short, this negative study showed us that, and the reason it was negative was the company thought that secukinumab was going to be superior to adalimumab, which it is not. However, inflammation control, whether you do it with TNF inhibitor or IL-17 inhibitor, controls new bone formation. I got a couple of more slides to tell you about the future of IL-17A inhibitors or IL-17A plus F inhibitor, and that's sonelokimab. So these are cameloids, alpaca and llama, and they have these nanobodies as part of their immune system. And a nanobody is a single domain antibody derived from the variable chain. So here is the regular antibody, and there is this heavy chain and the light chain, and then this is the variable region and the constant region. And if you take only the variable region of the heavy chain shown here, 15 kilodalton, that's a nanobody. A nanobody is very small, 15 kilodalton as compared to 150 kilodalton. And the idea is that it penetrates, deep tissue penetration, but at the same time, it can be excreted by the kidneys very quickly, and that's why you attach it to albumin. So this is sonelokimab. This has got an anti-albumin domain. It has got anti-IL-17A domain and IL-17F domain. In my next lecture, Professor Coates will tell you about sonelokimab in psoriatic arthritis. There are no studies yet on sonelokimab in axial spondyloarthritis done. So where would we be using IL-17A, whereas IL-17A and F inhibitors? And so there are no head-to-head studies. Where we will be using it, only time will tell. There are theoretical advantages of IL-17A plus F inhibition, such as that it might be able to block inflammation in the eye and might be helpful in preventing uveitis. Whether that will be true or not, our experience will tell, or a direct head-to-head study will be important to do. Thank you very much.
Thank you very much, Atul, for this very nice overview on IL-17 inhibition in axial SpA. We already have several questions in the chat. Don't leave us, we will address them. But now we will first move to the next speaker. We'll have all three presentations, and then in the end we will have a Q&A. So I would like to introduce again Professor Laura Coates, who is Professor and Senior Clinical Research Fellow at the University of Oxford, and who will tell us about the role of IL-17A and IL-17AF dual inhibitors now in the management of PSA. Laura, please, go ahead.
Thank you very much. And obviously it's easy to follow on from Atul's lovely summary of the different medications, and you'll see the same drugs and issues, I think, coming up in PSA as well as in the axSpA. So these are my disclosures. So the learning objectives similar really to Atul's, but thinking about PSA is to look at the clinical data on efficacy and safety of IL-17A inhibitors and the IL-17A/F dual inhibitors in psoriatic arthritis, to discuss some ongoing clinical trials and some new inhibitors that are in development in that IL-17 space. And to think about how IL-17A and IL-17A/F dual inhibitors factor into current treatment and impact on our clinical practice. So as you've heard from Iain at the beginning, IL-17 obviously is a key cytokine in psoriatic disease, and IL-17 inhibitors are recommended for use in psoriatic arthritis. Up until relatively recently, we had 2 previously approved medications, which were both IL-17A inhibitors, secukinumab and ixekizumab. And then bimekizumab is the newer IL-17A/F inhibitor. So we're really lucky in psoriatic arthritis, and this is where I think we have life a little easier than in axSpA, because we do have quite a wide range of medications available to us in PSA, and all of these different drugs are effective in at least some domains of psoriatic disease. And selecting those drugs, I think, gets more and more complicated for different patients. We've got an abundance of drugs, although we still have patients that sometimes don't respond. Obviously following on from TNF inhibitors, IL-12/23, the most recent IL-23 inhibitors, today we're really focusing on the IL-17 inhibitors. So secukinumab was the first IL-17 and specifically IL-17A inhibitor to come through for psoriatic arthritis. And this summarises the key data from Future 1 and Future 2. And you can see, obviously, the benefit for secukinumab over and above placebo. And in these early trials, you can see in Future 1, 75 and 150 milligram were tested. In Future 2, it was 75, 150 and 300 milligrams that were tested. And that dose piece is obviously carried through into clinical practice, thinking about the optimal dose for patients. So here we're looking at the psoriasis outcomes, at the skin outcomes, and in contrast to the previous slide where the 150 and the 300 milligram doses seem to perform quite similarly, here you can see why we use the higher dose for patients with significant skin disease. So you can see a clear dose response with the different doses of secukinumab and a benefit for being on the 300 milligram dose. And obviously the other area where we use the 300 milligram dose is in patients who've previously failed a drug. So you can see here in the main blue bars, the data on the patients who are TNF naive. You can see here no separation between the 150 and the 300 milligram doses, although both are better than 75 milligrams, hence the license. But in the kind of stripy bars, you can see those patients who've previously had an inadequate response to a TNF inhibitor. And here you can see the benefit for that 300 milligram dose over and above 150. So when we're using secukinumab routinely in practice, we're using 150 milligrams for patients who do not have significant skin disease and who are TNF naive, and 300 milligrams for those with significant skin disease or those who've previously failed a TNF. And there's now increasing doses actually on increasing data on increasing doses, and thinking about even higher doses of secukinumab, particularly for patients with significant skin disease and with obesity. And then obviously the kind of second IL-17 that we had available to us was ixekizumab, another IL-17A. And here you can see the different doses of ixekizumab from the original trials, but here with an adalimumab comparator drug. So you can see here placebo in the grey, adalimumab in the yellow, and ixekizumab in red. And here you can see no real difference between the different ixekizumab doses, but I think you get the idea of a similar outcome in terms of ACR outcomes on the left of the slide, but clear superiority for IL-17 over and above anti-TNF when we think about the skin. for all the different PASI outcomes that are shown here on the right. And that was really borne out in a specific head-to-head study. So we don't have a huge number of head-to-head studies in rheumatology. There are many more in the psoriasis dermatology space. But this was the first head-to-head study to report results in rheumatology. And you can see here they compared ixekizumab, IL-17A versus adalimumab. This was an open label study, although the assessors were blinded. The patients were randomized 1-to-1 to ixekizumab or adalimumab, and they recruited patients who had active PSA and who also had at least 3% body surface area of psoriasis. So this was a slightly enriched group for those who had significant skin disease. And the primary outcome is shown on the left here with ACR 50 plus PASI 100. So this was a novel outcome measure. This wasn't something that had been developed previously or tested in other trials. It was really specifically designed for this study. And it's looking at patients who achieve both of those outcomes, the ACR 50 and the PASI 100. And obviously, clinically, you can see the usefulness of such a criteria. So thinking about a good skin outcome and a good joint outcome. And you can see here that ixekizumab in the red was superior to adalimumab for that combination outcome. But I think as you look at the secondary outcomes across the slide, you can see similar outcomes again for ACR 20, 50 and 70. So no clear benefit in the joints, but that benefit in the combined outcome measure is very much driven by the PASI 100 on the far right-hand side of the slide, where again you can see the benefit of IL-17 over above TNF. Then following on, we had a second head-to-head study, having complained that we never got any. We got two in quite relatively short succession. And this was the EXCEED head-to-head study. So this study looked at secukinumab, IL-17A again, versus adalimumab, the same. But this study was a little bit bolder. So it used ACR 20 as the primary outcome. So not a joint and skin combined outcome, but a specific joint outcome. And you can see here, if you look over the course of the year, as shown in that plot, you can see pretty similar responses initially, but then you do start to get maybe a little bit of separation between the two drugs, although that didn't reach a statistical significance. And then on the right-hand side, you can see the ACR outcomes and the PASI outcomes again, with a slight numerical benefit, as you can see for ACR 20 from the other graphs, but the clear benefit again for skin disease. So really, we've got consistent data that the IL-17s are as good for joints and better for skin compared to a TNF inhibitor. And then coming on to the IL-17A and F inhibitors and bimekizumab. So this is the BE-OPTIMAL study. This was the initial phase 3 study of bimekizumab in patients who were TNF naive. And here you can see, again, there's an adalimumab comparator group here, as well as a placebo. And these patients are placebo-controlled up to week 16, and then the placebo patients switch on to active therapy after either week 16 or week 24. And then in parallel to this, there was a study in patients who were TNF experienced. So patients who previously had an inadequate response were randomized either to placebo or to bimekizumab. Here, obviously, there isn't an adalimumab arm because most patients, I would imagine, have probably tried that already. And here, again, we're looking over that 16-week time point. And the primary outcome for both of these studies was the ACR 50. So moving on, I think in recent studies, we've accepted that while ACR 20 is a useful outcome measure for comparing drugs, it's not really where we want our clinical responses to be. And so having ACR 50 as the primary outcome here, I think, is positive in terms of thinking about improvement for patients. So you can see here a good response for bimekizumab compared to placebo. This was obviously statistically significant across all of these different outcomes. And you can see the comparator data for adalimumab here as well. This isn't a powered head-to-head analysis here with adalimumab. This is an internal comparator group only. Thinking about minimal disease activity, this is at 16 weeks. So this is very early to be assessing minimal disease activity, really. Usually we would expect to assess outcomes like this at a later date. It takes maybe 16 weeks to respond to a drug, but longer for everything to sort of start to normalize and to get to levels of remission or minimal disease activity. But despite that, you can see very good outcomes with over 40% of people achieving MDA at week 16. And then the enthesitis and dactylitis data, obviously these only affect a subgroup of the patients in the main study. So this was a pooled analysis where they put data from B-optimal, the TNF naive and B-complete patients together and looked at that overall. And here you can see the benefit over and above placebo. Thinking about safety, I think this is very much in keeping with what you'd expect with an IL-17 inhibitor. So there's a small number of serious adverse events, pretty low number of serious infections, obviously a higher rate of fungal infections compared to the adalimumab or the placebo group. And in this trial, there were no cases of inflammatory bowel disease. And then B-complete, as I mentioned, is those who've been TNF experienced before. Again, the primary outcome is ACR 50, and you can see a really strong benefit for drug over and above placebo. And obviously these patients are harder to treat, but really with a very similar response or differential response between drug and placebo, as we saw in the previous study. Again, very good data with MDA. So these are resistant patients, or at least partially resistant, who've been through a TNF inhibitor. We're still getting MDA results of over 40% at 16 weeks, which is pretty early. And then, of course, this is the same pooled enthesitis and dactylitis data. And again, in terms of safety, as you'd expect, there were a few serious adverse events, 2 of which led to study discontinuation, and in particular, a higher rate of fungal infection seen compared to placebo. So if you look at the 2 studies side by side, this is the B-optimal biologic naive on the left and the B-complete, the TNF inadequate responders on the right, you can see actually how similar these responses appear to be. And I think that's a real benefit. A lot of the patients that we treat now in our clinics have experienced a TNF. That's typically our first line of choice, at least in Europe, for a lot of these patients. And so this is a group where we really need good data, where we need confidence that the drugs will work well. And you can see a very good delta between the placebo and the active drug, even in those trickier to treat TNF experienced patients. And then all of the patients who were willing to do so from B-optimal and B-complete went into a long-term extension study. So the initial B-optimal study was 52 weeks, B-complete was only 16. And after that time period, they then went into B-vital. And at that point, all of the patients are receiving open-label bimekizumab, 160 milligrams every 4 weeks. And over time, and there's obviously more data to come, we keep getting additional years of data for this being released. You can see evidence of long-term efficacy. You can see here the top row ACR 20, middle row ACR 50, our primary outcome for these previous studies, and then the ACR 70 at the bottom. And you can see good maintenance of response out from 16 weeks or a year in the initial study out to week 104 in B-vital. Now, obviously in psoriatic arthritis, we're also thinking about other domains of disease. I've mentioned a bit of the data on enthesitis and dactylitis. This is data from the Be-Ready psoriasis trial, which had 2 co-primary outcomes, so PASI 90, where you can see a very impressive difference against placebo, and the IGA 0 or 1, so showing the magnitude of response in terms of psoriasis with bimekizumab treatment. And there have been a number of head-to-head studies. So this is bimekizumab compared to ustekinumab, shown here in the green. The same co-primary outcomes with PASI 90 and the 0 or 1 kind of static scale. And you can see a clear benefit for bimekizumab over and above ustekinumab. And then a further head-to-head against adalimumab here. You can see here 2 different doses of bimekizumab, same co-primary outcomes, but here comparing to adalimumab and showing a clear benefit for bimekizumab over adalimumab in skin psoriasis. And then obviously thinking about that difference in the drug designs, here we're comparing the IL-17A and F bimekizumab with an IL-17A inhibitor. So this is secukinumab shown here in the red. The primary outcomes PASI 100, as you can see here. And you can see a significant benefit for bimekizumab over and above secukinumab for that PASI 100 outcomes at 16 weeks. So showing the benefit of the dual inhibition, as Iain alluded to. And then Atul mentioned the kind of novel agents that we have coming through. So novel IL-17A and IL-17A and F agents. So sonelokimab, as was mentioned in the previous talk, is an IL-17A and F targeting nanobody. So this is around 40 kilodaltons, and they have phase 2 data in PSA. Izokibep is an IL-17A targeting small protein. This is only 18 kilodaltons. So izokibep is the smallest. That compares to a monoclonal antibody of around 150 kilodaltons. So they're both considerably smaller than a monoclonal, but izokibep even smaller than the sonelokimab nanobody. But you can see here again, one is an IL-17A, one is an IL-17A and F targeting drug. So if we look at izokibep, this is data from the phase 2b/3 trial of izokibep versus placebo, and it really behaves as you would expect. So you've got good ACR50 results here over the 16 weeks compared to placebo, pretty similar in terms of the 2 doses of izokibep that were tested. And again, good data for MDA. Again, a relatively early time point at 16 weeks, but very similar outcomes as seen in the previous study, thinking of around 40% achieving MDA at week 16. And then with sonelokimab, this is a phase 2 trial. You can see the different doses here in the green, looking at week 12 and at week 24 outcomes. And you can see here a good benefit over and above placebo for the different doses of sonelokimab. And this is one of the first phase 2 trials that I'm aware of that's had an adalimumab comparator arm. We've seen them a little more in phase 3, but not so much in phase 2. But this gives you a nice idea of how the drugs may behave in the same population. And when we look at MDA responses, again, good outcomes here. So at week 12, that earlier time point, a little bit lower, but still with one of the doses, you're hitting that 40% threshold. At week 24, when people have been on drug a little bit longer, it's more in the 50 to 60% range with sonelokimab. So I think the big question that we still have is this lumping and sitting within IL-17. So we've got IL-17A and F inhibitors. We've got IL-17A inhibitors as monoclonal antibodies. And then we've got IL-17A small proteins and IL-17A and F nanobodies. And I think the big question here is how much do these different structures influence the clinical outcomes? You've seen head-to-head, there's a benefit in psoriasis for IL-17A and F over and above IL-17A. There are lots of theoretical arguments with the nanobodies and the small proteins that they may be able to penetrate tissues better, that the albumin binding may help with that, that they may get better results or more consistent long-term results. But we really don't have the clinical data that backs that up. So far, the data from the small proteins and the nanobodies looks as we would expect really for an IL-17 monoclonal antibody. So time will tell with further data from these drugs. And obviously sonelokimab is only in phase 2 at the moment, where we need more data to see if the differences in structure really translate to a significant benefit for patients in terms of clinical response. So they are very much part of our available therapies and armamentarium in psoriatic arthritis. I think IL-17 inhibitors have a big role to play across all 6 domains of psoriatic arthritis. Very good data in skin, as Atul showed, evidence of efficacy in the axial component of disease, as well as, of course, of the peripheral disease. But I think it's an increasingly crowded space, and so we need to think about how we select the different drugs that we have available to us for each individual patient. So if we're selecting different drugs for different patients, I think we use a lot of TNF inhibitors still in psoriatic arthritis, with evidence across all 6 domains. They work well in skin disease, also in IBD and uveitis. And they're typically, at least in Europe, a first-line option as a biosimilar. Ustekinumab, I think we use less of, so it is a bit better for skin than a TNF inhibitor. Where I do have patients on this, and it's often because they have inflammatory bowel disease as well. But there's a concern that this wouldn't work in axial disease. IL-17s, obviously, as I've mentioned, good data across all 6 domains of psoriatic arthritis. You've seen the benefit in skin disease over and above a TNF inhibitor, and that's also true over ustekinumab as well. But obviously, we would avoid IL-17 inhibitors with patients with active inflammatory bowel disease. IL-23 inhibitors, good as well for severe skin. Some data around inflammatory bowel disease, but no data for axial disease at present, although further studies are ongoing. And then the JAK inhibitors obviously give us an oral effective option, but more for the mild to moderate skin. Positive data, as Atul showed as well, in axial disease, some early positive data in IBD as well, but obviously with a safety concern that we've seen from the rheumatology literature widely. So in summary, I think IL-17 inhibition is a really important treatment option for psoriatic disease in both skin and joints. Bimekizumab, as we've seen, is a novel IL-17A and F monoclonal antibody, and there's very strong phase 3 data which provide insight into its efficacy in treating arthritis, enthesitis, dactylitis, and skin disease. And in parallel with that data in axial spondyloarthritis, I think we have confidence for its efficacy in axial disease as well. We only have head-to-head studies with bimekizumab in psoriasis at present. We don't have any head-to-head studies at the current time with data in psoriatic arthritis. And then we've got these novel IL-17 inhibitors that are in development, 1A and 1A and F, but with very different molecular designs. And so it will be interesting to see what further clinical data from those new drugs brings us, and whether there's a significant clinical difference from those different underlying molecular presentations. And I will hand back to Sofia for some questions.
Thank you very much, Laura, and thank you very much, both of you, actually. And now we have some time for questions, indeed. And our audience has been very engaging and sending several questions, which is fantastic. I was going to start with Atul, but Atul has also been so proactive that he has already addressed his questions in written. So I think I will continue with you first, Laura, and not give you any break. But in the meanwhile, I would like to invite our audience to please continue and post your questions. We will be addressing them. We still have time for this Q&A session. So Laura, starting with you, there were questions on the trial from secukinumab against adalimumab in PSA, whether the primary endpoint was a non-responder imputation on less observation carried forward, and with the hypothesis or the interest in knowing whether results could be driven by patients dropping for lack of skin response.
Yeah, so this was, I think when you have a trial that's sort of so close to a p-value like this, where you may be expected to see a difference, clearly, I think the investigators were looking for that difference there, then exactly how you analyze the data makes a difference. And I think in the run-up to the study, what was decided was that the primary outcome would be with multiple imputation. So they used multiple imputation for missing data, and actually, had they picked a different method, some of those did meet statistical significance. So it was very close. There's also been some discussion about the sex differences. So we've seen lots of data in the last 5 to 10 years thinking about sex differences in outcomes. Generally, women do worse. That's pretty much universal in nearly all the studies. And there was an imbalance in this study between men and women in the different arms. And that's something I think we're learning from. So that Moon Lake phase 2 study that I showed you actually used sex in the stratification, in the randomization. And I think that's something that, particularly with head-to-head studies, where the differences are going to be smaller, I think we need to think about controlling for sex coming into the studies to make sure that we get a fair comparison.
Thank you. Very good points. And continuing on the measurement and on the endpoint specific for trials, the same trial and also IL-17 inhibition versus adalimumab. What was the endpoint for enthesitis and dactylitis?
Yeah, and again, this gets discussed a lot as well in trial design. The data that I showed was around resolution because it's a nice, clear outcome. It got better. It only includes those patients who had enthesitis and dactylitis at baseline. So there's a possibility that some people didn't have it at the beginning and developed it at some point during the study. Those won't have been included. And again, there's been debate about exactly which enthesitis measures you use, whether looking at more sites is more sensitive to change, whether you need to use dactylometer for dactylitis. And I think this is one of the tricky things we have when we're looking at guidelines or meta-analyses or combining data from different studies, is a lot of the different studies do slightly different things. So it makes it hard to compare. But I think there has been a positive shift in recent years to thinking mostly about resolution. And I think that makes sense from a patient point of view. Patients want to be better. They don't want to be a 50% improvement. They want for it to go away.
Yes, thank you. And now regarding bimekizumab, the study, there's a comment that it's odd actually that in patients who are TNF inhibitor insufficient respondents, that they have numerically did better than TNF inhibitors naive. Does this make sense?
Yeah, so I mean, obviously it's always tricky. There are lots of differences between these different studies. They're run often at similar centres, but they do vary. TNF inadequate responders is a mixed bag of patients. That's somebody who's tried one TNF, somebody who's had drug for a long time, primary failures, secondary failures. I think what's really clear when you look between the studies is the placebo response is very different. So those who've experienced a kind of a failure to respond to a medication, I think don't get the same placebo response, which is helpful. We've seen that really go up in recent trials. And generally speaking, the delta for the different outcomes is similar between the two trials. So the difference between the placebo and the active drug. Generally speaking, they're both lower in the experienced studies, but for some outcomes, you do get a better outcome. And they are just different populations. I think it's hard to look too much into that. But it is definitely positive that we're not seeing a big drop off in response in those who've previously had a TNF.
Exactly. I think it's a situation where we can look at the glass half empty or half full, whether we can trust the results and questions can rise from this. On the other hand, it's indeed very reassuring, as you were saying, Laura, that we don't see clear differences. So that can be a very positive aspect of the drug. We have a question also about brodalumab that we haven't covered in this webinar so far. And why hasn't it been mentioned in the discussion? Could you perhaps mention it, Lara?
Yeah, so brodalumab obviously is another different type of IL-17. It's a receptor blocker, so it's potentially targeting the different types of IL-17 because it's hitting the receptor and therefore blocking A and F. Obviously, that was very strongly in development in psoriatic arthritis, and then there was a relatively big scare around its use from the psoriasis trials predominantly, with increased risk of suicidal ideation. And that's something that's been looked at very carefully in all of the IL-17 studies since as an adverse event of special interest. So it is a drug that does get used now in dermatology, but it's not something that we have access to currently in rheumatology. And I don't know of any immediate plans to bring it to us and to the clinic on the rheumatology side.
And on a similar note, there's a related question. Do we have any thoughts on targeting IL-17 receptor versus the IL-17 itself?
Yeah, I mean, potentially it is an IL-17A and F blocker. It's blocking both drugs. I think obviously that there has been this concern around safety, and that's something we've always got to balance with efficacy. If you look particularly with the higher dose of bimekizumab in the psoriasis trials, it does seem that the fungal infections are probably worse and a little bit more significant than the IL-17A and only inhibition. So whenever you block more, there's potentially a higher risk of side effects. The suicidal ideation question, I think, is tricky. Obviously, our psoriasis and PsA patients often come in with quite significant mental health problems. A lot of the patients coming into these trials did, and that doesn't help. But there was, or there did appear to be, a significant signal with brodalumab, which is why the development halted at that stage.
Yes. And now moving to difficult to treat patients, where they're against the broad spectrum of modes of actions that we now have and treatment options. How do you consider, how do you evaluate combinations of treatment options for the future? And here I imagine we're talking about biologic and targeted synthetic DMARDs, of course.
Yeah, I mean, I think this is an area of interest for sure. If you look at the literature and some of the studies and abstracts that we've seen coming through, I think it's always a balance. We got scared years ago with combination therapies with rheumatoid and the potential safety implications of that. But we've seen very positive data from the Vega trial in ulcerative colitis, looking at combinations of IL-23 and TNF inhibitors. There's some nice reported kind of case series looking at combination therapy in psoriatic disease and spondyloarthritis. Obviously, it's not cheap. It's not something that I find easy to do in my practice and easy to access. And the majority of case series and of the cases that I have personally in my practice are patients who have two different conditions, because otherwise we just wouldn't get the funding for it. So the majority are patients who have, for example, IBD and some form of spondyloarthritis, where one consultant can prescribe one drug and the other consultant can prescribe the other drug, and you can sort of work together. And I think there are positive data in terms of efficacy in what are generally quite difficult to treat patients who have resistant disease and usually two resistant diseases as well. But even in relatively small case series, there have been reports of serious adverse events and serious infections, potentially up to around 10%. But it's really difficult because we're talking about very small numbers, and so it's hard to be confident on the risks of that. And the combination that you choose, for sure, is going to influence that chance of an infection risk. But I think it is definitely something that's being looked at more. And obviously with the overlap between IBD and axial disease as well, I think it's something that, although you have less drugs to choose from in axial disease, gives us options for some of our axial patients with IBD as well.
Indeed, and that may also be an opportunity to learn more about these potential combinations. But from your answer, I think you kind of hinted also, actually, we would need trials for this, because if we're basing this co-treatment only on case series, which also have publication bias, etc., it becomes challenging, and not to mention costs, which you already mentioned as well. And now combination therapy, a usual question in PsA. Whether to combine IL-17A blocker with the methotrexate, yes or no, whether it's more efficacious or not?
So no clear data. So the data obviously in PsA for anti-TNFs is where we have the most data. There's no evidence of better efficacy in the short to medium term, but there is some evidence of better drug survival in the longer term, particularly with the monoclonal drugs over and above etanercept. With IL-17, we haven't really got any data that shows a significant benefit. But I do think anecdotally that in some patients it makes a difference. And I have some patients who've stopped their methotrexate and then wanted to go back on it. You never know how much that's a placebo or a nocebo response when they've stopped a medication. Overall, I think it's less relevant in those with IL-17. I probably practice slightly more unusually because we have significant restrictions in our region on number of medications, and we probably leave more people on concomitant DMARD because we're always worried about drugs running out of efficacy over time. And that's us being overcautious, I think. It's not evidence-based, really.
Yes, indeed. We have another question which formulated in the Q&A. Maybe not entirely clear what the person meant. The question is, what are our problems with dermatologists? For example, they can change the medication if the skin is clear, but the joints are inflamed. Do you want to say something about this, Lara?
Yeah, I mean, we have to work together, and I think it is tricky. Generally speaking, I find it's easier to control the psoriasis than it is to control the arthritis, but not always. Sometimes the psoriasis can be really tricky to treat, and it's having a good relationship with your dermatologist and running things past each other. There are some situations where they'll contact us if they're thinking about changing medication, to say, you know, we're looking for a change. We could use drug A or drug B. Which would you prefer? That's always really helpful. We will always check with them. And I think less of an issue currently, but as different drugs get approved on different timelines, sometimes you can access other drugs quicker through the other specialty. So often drugs get licensed in psoriasis first. So for patients who are running out of options, we need a new drug. Sometimes they can prescribe it for the skin. But I think it is really difficult when somebody's skin has got better, but their joints haven't, or somebody's joints have got better and their skin hasn't. You don't want to lose that response that you've got, particularly if it's your aspect of the disease that is controlled. You don't want to sort of throw that away, and neither do the patients. But you've got to take into account both aspects of the disease, and it's trying to really optimize treatment in both skin and joints.
Yes, thank you, Atul. Now we can move to you and ask you some more questions now that you have addressed all the questions that were in the chat from our participants. I was wondering whether you could comment a little bit on why do we think that bimekizumab can demonstrate superiority in psoriasis, but such a trial is perhaps less promising in rheumatology or less certain and therefore less conducted, and actually the same fits for actual SpA and for PSA, because it's true that in none of the diseases such a trial has been run. Any thoughts on this?
Yeah, I don't think that I can give you a clear answer as to why these drugs show superiority in skin, but not in the joints. I actually would like to, I was, when we were listening to Iain McInnes, one thing he said was that the immunology in different organs, well, it affects, it's active in different organs in a different way. I'm paraphrasing him. So what is happening, and he was giving the example of skin and the eye, and he was saying that how skin has got large surface area, eye has got a small surface area, but it can have significantly different effects on the patient's life and quality of life, and etc. That was his point. But at the same time, he also mentioned that there is hierarchy, and this is now I'm using one of his old papers, that there is a tissue hierarchy, and IL-17, which is kind of important for the skin and joints, and sort of blocking IL-17 is important because it's inflammatory in the skin and joints. But the same IL-17 in the gut is actually protective. And I'm so getting back to your question, somehow our diseases, our drugs, cytokine blocking agents are more effective in the skin, and patients there, even their outcome measures dermatologists use are PASI 75 and PASI 90 and PASI 100. And even for TNF inhibitors, we don't really have those kind of lofty sort of outcome measures. And so for some reason, good for dermatologists, they actually can show dramatic responses, whereas we actually have this glass ceiling for practically all our drugs. And there is a specific amount of ACR 20, 50, 70 that we get in RA or in psoriatic arthritis, and the same thing for IL-17. And it's very difficult to break that particular glass ceiling. And I think that there is something immunological here, that for in the skin, these same drugs are able to achieve much better response, whereas in joints and enthesis and etc., it is less. And one more additional point I want to make is that skin is very objective. You can see how much skin is cleared, whereas many of our, almost all of our, not almost all, actually all of our outcome measures, there is pain included in that. If you think about ASAS-40, and if you think about even ACR and the tender joints, and so that aspect of it makes it a little bit cloudy, because there is a little bit of patient's input into that, and the pain may not be controlled as well as the clear skin that you can see. It's a very objective. There is a subjectivity in our outcome measure. So apart from the immunological explanation, there is this another explanation which I would like to add there. Sorry for a long answer, but this is the way I would think about it.
It's very good, because you brought me to the next question I was going to ask, and you kind of already answered it, because I was going to ask you, do we need better outcome measures so that we can find some different effects that we are not capturing and that are being captured in the skin? Or is it really the tissue that makes the difference and not the outcome measures? But I think you also already alluded.
Yeah, I mean, we definitely need different and better outcome measures. I've always been very surprised as to the 5-year-long studies. And there was one study which I mentioned, Be Agile, the bimekizumab study in phase 2 study in axial spondyloarthritis. And at the end of 5 years, there are patients who haven't even achieved ASAS-20 response. Why are they still in the study after 5 years? I mean, there is something that they feel there is a value to that drug, but our ASAS-20 response is not capturing that. Same thing, I was involved in the golimumab study, 5-year study in ankylosing spondylitis, radiographic axSpA, and there again, there were 20% of patients not even ASAS-20 response. And you'll see this in RA, and you'll see this in PSA, and everywhere. So clearly, our outcome measures are not capturing what the patients feel is important for them. And so that is one aspect. And the second aspect is, of course, that is, we don't have a good measure of pain apart from the patient telling you how much pain they have on a scale of 0 to 10. Objective measures of pain. There's a lot of work being done in here with fMRI, functional MRI, and there are ways and means you can measure the pain with quantitative sensory testing, QST. We do that kind of stuff at my center. But they are not yet ready for prime time. So you're absolutely right. We definitely need the fatigue, which is another very important problem the patient has, and that clouds their outcome. How are you feeling on a scale of 0 to 10? It clouds their, well, it's not cloud, but it actually, fatigue and pain makes them say that I'm not doing that well. And there are so many other reasons for these two most important symptoms rheumatology patients are telling us. And we don't have good outcome measures for pain and fatigue apart from visual analog scale, 0 to 10. There is no objective way of measuring it. So yes.
So work to be done. Yes. And comparing monocytokine related mechanisms, so for example, the IL-17 inhibitors versus the multicytokine related mechanisms by JAK inhibitors, do you see clinical differences in terms of, for example, pain alleviation? Atul, for example?
So there is, yes, I've thought about this because the JAK inhibitor companies are mentioning that our drugs help with pain separate from the inflammation part. And patients, I mean, again, I haven't measured this myself, but there is a possibility that JAK inhibition has effect on pain independent of their effect through inflammation. We do statistical analysis in different ways to find out, tease out this point. But direct measurement is, again, very, very difficult. I mean, again, we may have to do fMRI, functional MRI experiments, or some other way of finding out that patients who have got completely controlled inflammation. Our inflammation measurements are also not very good, at least in the axSpA. Outside of CRP and then MRI, we have nothing else to look for inflammation, and the CRP may not be high even in patients that we clinically think has got active disease, but 50% of the time, or even more, 60% of the time, CRP can be normal. So our inflammation outcome measurements are also not very accurate. But getting back to your original question, I think there may be, I cannot say this definitively, but JAK inhibition may be also affecting pain in a separate way outside of their effect on the inflammation.
Thank you very much, Atul. We can all get very engaged onto these discussions, and we could continue. There are more questions from our participants, to whom I would like to thank for their active participation, but it's indeed time to close this webinar. Before we do that, I would like to thank all of you, thank all the speakers who have made this webinar possible, and the participants who have contributed with their questions. And before you leave, I would like to ask you participants to complete an evaluation form that can help us to shape these webinars in the future. So please give your honest feedback. Tell us how you would like us to run these webinars, because we would like to hear from you. And the live streamed version of this webinar will be available to view on the IMID Forum YouTube channel soon. And once again, thank you to all our speakers. Thank you to our sponsor, UCB, who has supported us through an independent educational grant. And more information on our IMID Forum. If you haven't registered yet, go to the website imidforum.com and register. Available, and all materials are available for free for you. Thank you very much, everyone, and see you next time. Goodbye.